a very good afternoon to all our viewers. World Sight Day is an annual day of awareness held in October to focus global attention on vision impairment, including blindness. This year, World Sight Day will take place with the theme Love Your Eyes. Now, globally, at least 1 billion people have near or distant vision impairment that could be prevented or has yet been to address. Vision impairment affects people of all ages, with the majority being over the age of 50. Vision impairment and blindness can have major and long lasting effects on all aspects of life, including daily personal activities, interacting with the community, school and work opportunities, and also the ability to access public services. Unoperated cataract and uncorrected refractive error are the leading causes of vision impairment. Other causes are also such as age-related macular degeneration, glaucoma, diabetic retinopathy, infectious disease of the eye, and trauma. However, it cannot be ignored and need to be addressed. For this, we have organized this session jointly by Sipher, which is the Strategic Institute of Public Health Education and Research, and Doplexes. So inviting Dr. Rakesh, President Sipher, to take this session ahead and also introduce our speaker for today.
So dear viewers, you are all welcome. I am Dr. Rakesh Gupta, President Sipher and former Director Health Services Punjab, and my co-host is Ms. Darshika Shah. She is a Senior Clinical Engagement Specialist, Doplexes Online Private Limited. And we welcome you all for this special presentation on latest developments in the corneal transplant surgery, recorded for Doplexes and Sipher Health News Channel. And this coincides with the World Sight Days 2022 celebrations. And we feel honored to have with us an eminent ophthalmologist and a cornea surgeon, Dr. Ashok Sharma, with us. So World Sight Day, we focus the world's attention on the importance of the eye care. We are calling all stakeholders to help people prioritize their own eye health and leaders to ensure eye care is accessible, inclusive, and affordable to everyone and everywhere. Nearly everywhere everyone on the planet will experience an eye health issue in their lifetime. However, more than 1 billion people worldwide do not have access to the services they need to see clearly. The Love Your Eyes campaign encourages individuals to prioritize their own eye health while advocating for accessible, affordable, and available eye care the world over. Working together, we are hoping to have 5 million sight tests pledged, host screenings, and show the world how to love your eyes with our fun and engaging social assets. So I welcome Dr. Ashok Sharma. He is a Director, Cornea Center, and is ex-president of the Chandigarh Ophthalmological Society and founder, Honorary Secretary, Eye Bank Society, Chandigarh, and is also ex-member, Executive Committee, Eye Bank Association of India. He is a former Associate Professor, PGIME at Chandigarh. He is a Cornea Fellow of L.V. Prasad Eye Institute, Hyderabad. He was an eye consultant in Maryland, US, and has published 104 research papers in the peer-reviewed national and international journals, and has been awarded by American Academy. AAO Achievement Award 2009, then International Ophthalmologist Education Award, and International Scholar Award, Best Poster Pediatric Corneal Transplants. So he has been awarded abundantly by the American Academy. And his Best Poster Pediatric Corneal Transplant was also published in 2015. He presented it. And the Best Paper Award, SSI Conference for Fibrin Glue. And he also presented Dry Eye and GRA at National Conference 2000. Himachal Pradesh government, they awarded him for contribution in the surgery, and the Cornea Hero Award was awarded to us by Sipher in 2020. So we welcome you, sir. So you may please let us know about the latest developments in this cornea surgery. Thank you.
Good evening, everybody. At the outset, I would like to thank Dr. Rakesh Gupta for a nice introduction and the organizers for giving me opportunity to share my experience of performing corneal transplants. I have been involved in performing corneal transplants since 1988 and has been actively involved in eye banking. In fact, in Chandigarh, I was the one who initiated corneal transplant surgery and eye banking. We formed Eye Bank Society to enhance the number of eye donations, and from few per year to 250 per year, we could enhance in about 5 to 6 years. And since 2002, I am running my own center, and we are performing all types of corneal transplants. So corneal transplant were introduced by Zerm in 1906. He was the one who performed the first corneal transplant. And following that, there have been significant advancements in corneal transplant surgery. Cadaver corneas were used, then lamellar keratoplasty. First eye bank was introduced by Richard Townley Patton in 44. Edward Momini introduced graft rejection. So many advancements were done, and due to these advancements, we could perform corneal transplants in a perfect way. In these advancements, not only the surgical technique was improved, but also the control of post-PK astigmatism, post-PK glaucoma management, graft rejection, ocular surface disease, and improved eye banking. All these factors, they enhance the success rate of corneal transplant surgery. It was because of these reasons that we could perform corneal transplants in patients who had intractable glaucoma. We could control the glaucoma either with medical treatment, or we could perform glaucoma filtering surgery before performing the corneal transplants. Those patients who developed glaucoma following corneal transplants, again, we could easily control glaucoma because of these advancements. In graft rejection, there has been significant improvement, and we have a lot of agents with us which we can use. Of course, topical steroids remains the mainstay of prevention as well as treatment of graft rejection. But in high risk patients, we can always use FK506 tacrolimus ointment. We can also use cyclosporine. With the advancement of limbal stem cell transplants, we can also perform corneal transplant surgery in those patients whose ocular surface is compromised because of limbal stem cell deficiency. And most often we get patients of chemical injury who has blood limbal stem cell deficiency. In these patients, we have option of performing either autolimbal stem cell transplants in case of unilateral injuries. If we have bilateral, we can go for cultured limbal stem cell transplants or live related stem cell transplants. Because of these advancements, when we were celebrating the centurion birthday of corneal transplant surgery in 1904, we had so many new procedures which were introduced by these two gentlemen, Malise and Terry. Malise in 1998 introduced posterior lamellar keratoplasty, which was later on refined to DSEC, and finally DSEC, Descemet stripping automated endothelial keratoplasty. And also deep anterior lamellar keratoplasty was introduced. Because of these two procedures, the surgical armamentarium of corneal surgeon was widened, and he was now able to provide customized care to his cornea patients. We could do selective transplants or customized corneal transplants for patients depending upon which layer is involved. If the stem cells were involved, we have limbal stem cell transplants or even SLET. If we have epithelial problem, non-healing, we can go for corneal epithelial cultures. And then automated lamellar keratoplasty, deep anterior lamellar keratoplasty, we can use femtosecond laser to perform these procedures. Penetrating keratoplasty, of course, remains the gold standard for full thickness corneal opacities due to any reason. And this was the new introduction, DSEC, and more recently, DMEC. The sooner the DSEC was introduced, it became the gold standard for the management of corneal endothelial disorders. The number of endothelial keratoplasties or DSEC increased within no time. Lamellar keratoplasty we have been performing since long, for so many years, and these are the common indications like pterygium, climatic droplet degeneration, Salzmann nodular degeneration. We do trephination, and then we do layer by layer dissection, and we place the donor button. In deep anterior lamellar keratoplasties, the dissection is carried right up to the pre-Descemet's area, and then a donor disc from the donor eye, by just removing the epithelium, is placed and sutured. So in deep anterior lamellar keratoplasty, most of the stroma is removed, and hence the interface problem is not there, and that is the reason we get more visual acuity. Now, technically also, the anterior stroma differs from the posterior two-thirds stroma, and lamellar dissection in posterior two-thirds of stroma is easier because here the lamellae are regular and this area is more hydrated and get more easily swollen. So we are able to perform lamellar dissection easily in the posterior part, and we can go closer to the Descemet's membrane. These are some of the indications for which we do corneal deep anterior lamellar keratoplasty. But newer techniques were introduced: Mally's mirror image technique, visco dissection technique, big bubble technique, small bubble technique, double bubble technique, limbal approach, hydrodelamination, hooking technique. Of various techniques, it's the big bubble technique which is more popular. And in this technique, what we do is that we do the debulking of the cornea by removing anterior one-third of the stroma, and then we take the needle close to the Descemet's membrane in the pre-Descemet's area and then inject the air bubble. We get a air bubble, and because of the air bubble, we can separate the Descemet's membrane, and then we remove the stroma. So this is a procedure which is currently more preferred, and most of the surgeons, they use this procedure. And more recently, Professor Harminder Dua, he introduced Dua's layer. According to him, just before the Descemet's membrane, there is a pre-Descemet's area which is thickened. It's a collagenous layer, and which is 15 micron thick. It stains different than the rest of the stroma. So we have now two areas. One is Dua's layer, then we have Descemet's membrane, and then we have endothelial cells. So once we introduce the air bubble, there are three types of bubbles which we can get. The type 1 bubble is when you get between the Dua's layer and thin pre-Descemet stroma, and type 2 bubble is between the thin pre-Descemet stroma and Descemet's membrane, and type 3 bubble is mixed between type 1 and type 2. So after removal of the stroma, the type 1 bubble has rough surface, type 2 bubble has bare Descemet's membrane. And DALK is very useful in keratoconus patients and gives very good results. These are some of the other indications where we have used it successfully. Like this patient had multiple stromal foreign bodies, and we did DALK and has clear graft. the question arises, is bearing of Descemet's membrane necessary? And can we achieve it every time? Bearing of Descemet's membrane, if we can achieve it, then the visual acuity in DALF is equal to penetrating keratoplasty. It's not aim for every time that we aim for Descemet's bearing. We can also aim for Descemet's bearing only in the visual axis and not in the rest of the area. And it has been observed that if your residual stroma is somewhere between less than 65 microns, the vision will be comparable to penetrating keratoplasty. So residual stroma thicker or Descemet's membrane wrinkles or corneal or haze, all these factors, they affect the visual outcome. There are several advantages of deep anterior lamellar keratoplasty over penetrating keratoplasty. The most important being the endothelial rejection is much less in cases of DAL. It's considered to be an extraocular procedure. Endothelial cell loss is minimum. We need shorter duration of the steroids, and there is excellent wound strength. Whereas contrary to this, in penetrating keratoplasty, we can have like gross disorganization of the globe if we get trauma. The scar is full thickness and it always remains weak. There are certain indications where you should be very cautious, like macular dystrophy, advanced macular dystrophy, where there is endothelial involvement. And in these patients, DALF may not give very good results. Again, technically, it will be very difficult to perform deep anterior lamellar keratoplasty if the patient has developed corneal hydrops. So patient selection is very important. And during surgery, we may get micro perforation or macro perforations. There can be interfaces. We can get stromal keratitis, especially if the patient has herpes simplex keratitis. We can get double bubble if there is a perforation or micro perforation. So we have to counter that. The second procedure is Descemet stripping automated endothelial keratoplasty or DSEK. The indications are all those conditions where the endothelial cells are decompensated, like pseudophakic corneal edema, aphakic corneal edema, Fuchs dystrophy, posterior polymorphous dystrophy. Regarding the surgical procedure, we need to give a very small incision, less than 5 millimeter, and we fill the AC with the viscoelastic. Then the Descemet's membrane is stripped. And once we are experienced, we need not to use like Helon or viscoelastic to remove the Descemet's membrane. We can do it without that also. We can use air bubble also to remove the Descemet's membrane. And after that, on the artificial anterior chamber, we mount the donor cornea with sufficient scleral width. It should be around 2 millimeter sclera around the cornea. And then anterior 400 micron or 350 microns is removed. And then 125 to 150 micron thickness posterior layer of the stroma is taken, and this is introduced into the anterior chamber. Now, this is a very significant step, that is the insertion of the donor lenticule. The most important or the most common method which all of us have used in the beginning is a forceps method, and we fold it 60-40, hold it, and then place it in the anterior chamber. Then we place the air bubble, and the donor lenticule stick to the posterior corneal surface. We have alternative insertion techniques: Busing glide, Rosenwasser and tan endoglide. We have used endoserter. This instrument is a disposable instrument, and this is similar to IOL injector. You can see that there is a plate there, and then we have two knobs. Once we place the donor lenticule on the plate with endothelial side up, we take out the we rotate the button, and this plate is rolled, and it forms a tube with safely the donor lenticule inside that tube, and endothelial cells are well protected. And once everything is ready, then what we do is we remove this guard, black guard, and we place this tip of the instrument into the anterior chamber, and then we rotate the distal black buttons, and with that the tube opens again in the anterior chamber, and very gently, without damaging endothelial cells, it delivers the tissue into the anterior chamber. And finally we remove this instrument, we put a suture, put the air bubble, and we get very good result. So these are some of the results of our initial cases where we have not used endoserter, we have not used automated endothelial keratoplasty or dissection, and we could get good results. This lady below, she was operated 12 years back, and we did scleral fixation for her along with the DSEC, and she has clear graft now also. Then we changed our strategies and we shifted to ultra thin DSEC. In ultra thin DSEC, we use tissue which is less than 100 micron or close to 100 micron. Now the problem is again that sometimes the handling of very thin tissue becomes difficult. So EndoSaver came to our rescue and it always saved us. We could perform surgeries combined with phaco, like in this gentleman, and you can see that on day 3 the graft is very clear, and the donor lenticle further thins down, and if it is 90 micron in the beginning, it thins down to 60, 65 micron or 70 micron over a period of 3 months with very good results. Now this is very interesting patient. She was suffering from severe dry eye. She had rheumatoid arthritis, and she was basically deaf and dumb also. So there was no way that we could rehabilitate her. If we perform penetrating keratoplasty for her, it was sure that we are going to get corneal melt, recurrent epithelial defects, peripheral ulcerative keratitis, and we will lose the eye. And because of the ultra thin DSEC, we took this patient under general anesthesia and we performed DSEC for her under GA, and we got very encouraging, very good results. She is very happy, she is seeing, and we were also very happy. And DSEC has several advantages over penetrating keratoplasty. This procedure provides rapid visual rehabilitation. There is very minimal astigmatism because we have not cut the donor but cut the host button. There is decrease in the incidence of graft rejection. It eliminates the suture related problems, and there is no compromise on the globe integrity. So all those disadvantages of penetrating grafts are taken care of by this procedure. However, there are several issues, like you have to face sometimes donor dislocation and sometimes primary graft failure if the handling is more, or if your endothelial cell count is low on lower side. Sometimes we get interface, and significant endothelial cell loss during surgery is another worrisome problem. Another procedure, that is the decimal stripping endothelial keratoplasty, that is DMEC, is now in practice. Most of the surgeons are using this, and if you look at this procedure, again is having the components of descemetorrhexis, graft implantation, unrolling, centering, apposition, fixation. So all these steps are there. And now if we look at the management of corneal disorders, we can always perform confocal microscopy to decide whether the endothelium is normal or endothelium is abnormal. Now, if the endothelium is normal, then you can always go for anterior segment OCT and see what is the level of the corneal opacity, and you can perform according to the level of opacity the lamellar procedure. If your endothelium is abnormal and rest of the stroma is clear, then we can always go for DSEC or DMEC. And if the stroma is not clear, it's a scarred, then we will have to perform penetrating keratoplasty. Of course, femto-assisted penetrating grafts can also be performed. There are several new procedures in the horizon, like decimal stripping only. There are reports where if you have peripheral good endothelial cell reserve, then you just perform the decimal stripping in the center, and these endothelial cells from the periphery, they migrate on to this area, and you can get clear cornea. The corneal edema will decrease. In Peter's anomaly, the endothelial cell removal alone is very helpful, and they say that the endothelial cells which are periphery to the center, they again migrate to the center, and the clear cornea can be achieved. We have performed this procedure and we have found good results. Cultured endothelial cell transplants is another area which is being researched widely. ROCK inhibitors are again evaluated for their efficacy, and there are several reports from Japan where they have treated patients of corneal decompensation with ROCK inhibitors. Another area which is very close to my heart is pediatric corneal transplants. The children who develop corneal opacity or corneal problems, they need penetrating keratoplasty or corneal transplants. These are some of the acquired indications, and there are children who may have congenital problems with anterior segment dysgenesis. They may also need penetrating grafts. Infantile glaucoma with opaque cornea, again, they need corneal transplants, and we have performed several of these. This is the child who is 2 months old, and we performed corneal graft on him with very good result. The child below has bilateral glaucoma with bilateral corneal opacification. Again, we performed corneal transplant with good result. The problem with these patients is that we need the cooperation from the glaucoma surgeon, because after performing the penetrating keratoplasty in these patients, there is bound to be increase in the intraocular pressure, for which the glaucoma specialist has to increase either the medicines or sometimes he has to perform the surgeries. Now, this child is very interesting. He had sclerocornea, microphthalmia, microcornea, and she had bilateral problem. Her corneal diameters were vertically 8 millimeter, horizontally 8.5 millimeter. And we performed corneal graft on her right eye first, giving her 6 millimeter graft. Graft remained clear. She could see. Parents were elated and they wanted surgery in the other eye. Although we do perform surgeries in bilateral cases also, and we perform surgery on the other eye of this patient also, and with very good result. And she is now almost 4.5 years, and she is going to school, and she can read, she can do her routine activities, she can play with her friends, and we are very happy. This gives immense satisfaction to corneal transplant surgeon if you have a very good parents who could give you follow-up. This is another, so many patients we have operated, but this is another child whom we operated this during this fortnight only, about 3 weeks back. She is 13 months old, and we performed a very successful corneal transplant for her. Again, she had microphthalmia. This is all my team, along with all the children, my mentor, Dr. V.S. Narankari from USA. And whenever he visits, he does examine our patients and he encourages us. And there are some of these children are doing very well. And the girl on the right side, she came to me when she was in first standard in 2002. And in one eye, she had trauma and retinal detachment, and she could not regain any useful vision in this eye. Other eye, she was having severe allergic conjunctivitis, for which she was given steroids, and she developed infective keratitis and later on scarring. So I performed corneal transplant on her in 2002, and she remained under my follow-up. She's still under my follow-up, and she finally graduated and did join as a teacher. And now she is happily married and well settled in Australia. She does come for follow-up. She is having 6/9 vision in her in her only eye. So this gives us satisfaction that we are doing whatever we can do for the society and for these children for whom the corneal transplant is technically very difficult, and most of the surgeons, they do not want to involve themselves into this activity, reason being that it's very laborious work, and you have to remove the sutures very early. Sometimes you have to put these children to EUA repeatedly to take care of these children. So we have been doing this, and till now we have done more than 200 children, and for that we have also been awarded by American Academy of Ophthalmology, where we presented our work as a poster, and this was given as a best poster award. Of course, our work has also been recognized by Sipher, and they gave us a honor hero award, hero cornea award, and we are very happy about that. And in the conclusion, I would like to say that DALC and DSEC are the new surgical procedures. DMEC is picking up, and these procedures, they have expanded the armamentarium of corneal surgeons. And because of these procedures, we can provide a component therapy for the corneal surgeons. Future research to improve the visual outcome of lamellar corneal grafts is required, and some of the newer research which is being involved, I think will come up, and we may come up for our cornea patients some new solutions also. In the end, I would like to pay my gratitude to my donors, because without their families' noble act of eye donation, this work is not possible. So my heart goes to these families and to these donors, and they are very close to us, and we always remember them whenever we perform corneal transplants, and whenever we present anything related to corneal transplant. I am thankful again to Sipher for giving me this opportunity, and I would like to answer any queries if you have, and thank you very much for patient hearing.
So thank you, Dr. Ashok Sharma, for sharing with us this comprehensive presentation and showcasing your wonderful work in cornea surgery. And it is very, heartening to see that how many advancements have been made in cornea surgery. Like now, instead of, in addition to the penetrating keratoplasty, now we have deep anterior lamellar keratoplasty, then posterior lamellar keratoplasty, Descemet membrane endothelial keratoplasty, then Descemet stripping endothelial keratoplasty, and moreover, we have now femtocysted keratoplasty, Descemet stripping only, and cultured endothelial cell transplant. So it is wonderful to know about it. I am sure that general ophthalmologists as well as the corneal surgeons, they will all benefit from this task. Now I'll request my co-host to, if she has any queries and if she wants to ask any questions from Dr. Ashok Sharma, so she may please go ahead. Thank you.
Thank you so much, Doctor. We would now like to take a couple of questions. So my first question for you is, what cultural barriers do you face in the eye donations, and your expert opinion in tackling these issues?
Okay, so you see, we have barriers in eye donation, and reason being that there are a lot of myths regarding the eye donation in general public. And if we look at the various religions, there are religious barriers, and in every religion there are, and people need to understand that these are only myths, and then there is nothing truth in this in these myths. And like some of the myths in our society is that if somebody donates organs, then he will be born in the next birth with the deficient organ. Maybe if you donate eyes, you will be born blind, which is totally unbiased. There is no basis for that, and we need to dispel these barriers. And we had recently one conference organized by Sipher, again by my center, and along with the ROTO, that PGI MER, where we emphasize that all the religions, they are in favor of organ donation, and all of us need to take cue from the Buddhist. And there the faith is that if you donate organs, then you are going to heaven. If you donate eyes, you are going to heaven. So that should be the a lesson to all of us, and we should always do that, and probably they have the maximum donations. Even we, when I was in PGI and when I left PGI also, we were getting a lot of eyes from Dharamshala because they have a lot of Buddhist population. And when the eye donation has not picked up in our own country, we were getting a lot of eyes from Sri Lanka. And Sri Lanka is one of the major country which provides donor eyes to most of the countries in the West, also in the Muslim countries also, where the donation is very less.
Thank you so much. Moving on to my second question. Corneal graft failure due to rejection, although small, does add on to the list of corneal transplantation. So, how can a surgeon do his best to prevent graft failure?
This is very important question because all hard work we do is not worth if we get graft rejection. We have to understand that there are certain conditions where the incidence of the graft rejection is much higher. If we have corneal vascularization, especially deep corneal vascularization in the cornea before surgery, the risk of the graft rejection will be higher. If the patient is suffering from herpes simplex keratitis, risk of graft rejection as well as recurrence of herpes will be there. Patients who have chemical injuries, dry eye, and other problems where the vascularization is there, the incidence of graft rejection will be higher. So we need to treat these patients before taking these patients for corneal transplant. We need to do some maneuvers to decrease the corneal vascularization. There are several methods which have been described. One is you can use laser also, you can use diathermy, or you can use even like anti-VEGFs also in some cases before performing corneal transplants. And for herpes simplex patients, if we perform corneal transplants, we give them oral acyclovir prophylaxis for at least 1 year so that the recurrence doesn't develop in the graft basically. And then after performing the graft, in high-risk patients, we give IV methylprednisolone on day 1. And then we keep them on steroids for longer period on higher doses. And some of these patients who are at high risk, we also give them topical cyclosporine and tacrolimus ointment also to prevent the graft rejection. And we educate our all patients who receive corneal transplants to come for follow-up, and we tell them that if you every early morning you just check your vision. If your vision is dropped, come immediately. If you have any irritation or redness in the eye, come immediately, because your suture may become loose, and this loose suture may again predispose to the graft rejection. So we need very monitored follow-up, so that even if the patient develops the graft rejection, we can treat it early and we can get the vision back for the patient. So this is my strategy for preventing and for treating the graft rejection.
Thank you so much. One last question, sir. How should a surgeon ensure complications are minimized in corneal transplant surgery?
How the complications are minimized during the corneal transplant surgery? I think the best way to avoid the complications is to anticipate what is going to happen. And one should have answer to all these problems beforehand, that if something goes wrong, I will do this thing. Like suppose, for example, if we have to perform cataract surgery along with the corneal transplant surgery, there is always a possibility that you may get a posterior capsular rent. So that part we need to tell the patient beforehand that there is a possibility, and there may be a possibility that once we remove the host cornea and the intraocular pressure of the patient goes very high, and sometimes the posterior capsule is disrupted to the extent that we are not able to perform corneal intraocular lens implant at this stage. So that should be told to the patient that we may get this kind of problem, and if this problem arises, then we will act accordingly. If we are able to place the lens, fine. If we are not able to place the lens, then we will do it after the surgery, after 3 months. So anticipating the problems and explaining the problems to the patient, that is very essential. Now, if I have to do a high-risk patient, suppose the patient is having a fibrous ingrowth in the eye, I know in beforehand only that if I touch this fibrous ingrowth, there is a possibility that there may be an intraocular bleed, and if there is an intraocular bleed, it is possible that I may not be able to stop it. So, if you are doing that kind of high-risk cases, it's better to tell the patient that I'm going to make an effort, but it all depends upon how the surgery goes. So during this surgery, whatever measures are required, we will take care. But that if we tell these things to the patient, we are safe and we are able to manage these problems. Then I would say that some of the things we modify according to the situation, like suturing. If the patient is from a very far off place or something and cannot come for follow up, we always want to give him a watertight antechamber so that we don't get a wound leak, and check the sutures at the end of the surgery. There should be no loose suture, because if you have loose suture, you may have to reapply the suture again, you have to come back to the operation theater, you have to give again anesthesia, so that will be a cumbersome. So make sure that. And during this COVID period, we made certain modifications in our transplant surgery procedure. Like earlier, we were not very worried about whether we are when we were doing corneal transplants, that once we have injected the visco, we were not removing it completely, we were leaving it some of this. But during COVID, what we learned, that use minimum of viscoelastic substance when required, and if you have used it, remove it at the end of the surgery completely, so that you don't get post-op rise of intraocular pressure or post-op uveitis. Because if you have post-op rise of intraocular pressure, you will have to monitor that, treat that, and patient will be required to stay closer to your like place for more days. So some of these modifications have helped us during COVID period.
Thank you, Dr. Ashok, for being with us. And I'm sure that all the viewers will benefit. So that includes the general practitioners, the general ophthalmologists, and the cornea surgeons as well. And I'll just add that we need to involve all the stakeholders. I mean, the government, the private doctors, the NGOs, so that the backlog which is there regarding the corneal blindness, that can be reduced. So thanks a lot, Dr. Ashok.
Thank you so much. Thank you so much, Dr. Rakesh. And I thank the Sipher and doctors for giving me opportunity. Thank you very much.
Thank you so much, Dr. Sharma. And also thank you so much, Dr. Rakesh Gupta, for such a delightful session and your support in putting together this lecture. We are very grateful to our dear audience for their kind listening. Please come back for Sipher and Doc Lexis programs. And until we see you again, please take care and have a great evening ahead. Thank you so much.